Hello, my name is Karma Erickson-Hurt, and I'm going to give this lecture on the Introduction, History, and Philosophy of Palliative Care. You'll see that this is actually a fairly brief lecture, just to provide you with a quick overview of kind of the roots of our beginnings in hospice and palliative care. So we really, actually before we talk about the history of hospice, I want to talk quickly about the objectives for this lecture. We're going to discuss palliative and hospice care, talk briefly about the benefits and hospice eligibility. We'll talk about our role in providing palliative care, and then discuss the roles of the interdisciplinary team and the value of having this interdisciplinary approach to care. But really, when we talk about hospice and palliative care, we really have to start off with the core history, and the name that comes to the front of everyone's mind when we're talking about hospice and palliative care is Dame Cicely Saunders, who was essentially the person who really started hospice care. The term hospice was essentially from the linguistic root the same word as hospitality, and it can be actually traced back to medieval times when it was referred to as a place of shelter or rest for weary travelers who were on a long journey. And the name was first applied by Dame Cicely Saunders as she was caring for dying patients in her work. And this was about in 1948, and she actually went on to create the very first modern hospice, which was St. Christopher's Hospice, which is located in the suburbs of London, England. She introduced the idea of specialized care for the dying to the United States in 1963 when she was visiting Yale University. Her lecture, which she gave to both medical students, nurses, nursing students, social workers, and chaplains about the actual concept of holistic hospice care, and in her lecture she included pictures of terminally ill cancer patients, their families, and it really showed the dramatic differences before and after symptom control and this concept of hospice care. And it was her lecture when she came to Yale University that really launched the beginnings of hospice care here in the United States and really launched the development of what we know as hospice here today. So I'm going to go to the next slide. And so this is where I'd like to talk a little bit about our history. So when Dame Cicely Saunders came in 1963 to do her lecture at Yale University, Florence Wald was actually the Dean of Nursing at Yale University in 1965, and she actually invited Dame Cicely Saunders to come and be a visiting faculty member for the spring term. And then in 1968, Wald actually took a sabbatical from Yale and went to go work at St. Christopher's Hospice in England to learn as much as she could about what this concept of hospice was. And then in 1969, another event started to occur, and this was actually Dr. Elizabeth Kubler-Ross, who many of us remember from learning about her stages of grief, denial, anger, bargaining, all of those that we learned so long ago in nursing school. But it was really through her work, and in 1969 she published a book where she interviewed over 500 patients who were dying, and her book was titled On Death and Dying. And it was because of this book that she identified the 5 stages through which many of these terminally ill patients progressed. And it really became an internationally known bestseller. She was one of the first people to actually publicize and start talking about death and dying and how we could do it better. And essentially what she did also was she made a plea for home care. Instead of treating people in institutions or hospitals like we'd had kind of come accustomed to, she argued that patients would do better if they had a choice about where they would die and participate in decisions about what their final days would be. And then in 1974, Florence Wald, along with 2 pediatricians and a chaplain, founded the Connecticut Hospice in Branford, Connecticut, and this was our very first hospice. And then in 1974, Canada developed one of the first initiatives in North America to improve a hospital-based palliative care. So that's when kind of it began in the hospitals, but it was more in Canada. In 1982, Congress started the Medicare hospice benefit, which we all know so well now. And then In 1997, the Institutes of Medicine published a report called Approaching Death, Improving Care at the End of Life. And essentially what this did is it documented glaring deficiencies in the end-of-life care in the United States, kind of opened up everybody's eyes to how we could better care for our dying patients. And then with the support of the Robert Wood Johnson Foundation and the George Soros's Open Society Institute, it really started the effort to bring palliative care into the mainstream medicine and nursing also. So really, when you think about it, 1997 really wasn't that long ago. And then in 2004, the first clinical practice guidelines for palliative care were published through the National Consensus Project for Quality Care. I have a separate lecture on that, so I won't say much more about that. But I do want to talk a little bit about nursing in particular and our specialty of hospice and palliative care nursing and kind of the history of, when you look here, our first nursing specialty exam really didn't begin until 1992, and that was initially called the Certified Registered Nurse Hospice, and it was the Hospice Nurse Certification Exam, and that didn't begin until, like I said, 1992. And then the CHPN, they actually changed the name of it in 1997 to the CHPN, Certified Hospice and Palliative Care Nurse. 2002 began the nursing assistant exam, and then 2003 was the advanced practice nursing exam, which we all know now as the ACHPN. And I actually took the second exam that they had in 2004. Maybe it was the second exam or maybe it was the third exam, but one of the initial exams that they actually took. So really, when you think about it, it really wasn't that long ago. 2004 was the LPN exam, and then 2008 administrative, and then our most recent exam, specialty exam certification, was in pediatrics, which began in 2011. So a little bit more about, I think it's important that we know about our specialty organization, and hopefully many of you are already members of HPNA, and HPNA is the Hospice and Palliative Nurses Association. It began out as the Hospice Nurses Association in 1986. And just so that you know, and we're going to talk about this more later in the course, but the NBCHPN, National Board for Certification of Hospice and Palliative Nursing, essentially is the one who manages our national exam, certification exam. Okay, now that we've kind of discussed a little bit about the background, like I said, that was pretty brief. There's, of course, a lot more to it, but that's really the gist of what you should know. And I want to talk just briefly about hospice and palliative care. Hopefully many of you have seen this or something similar if you've taken any other palliative or hospice courses before. Like I said, this module here is just a very brief introduction to hospice and palliative care, but it's important that we do talk about it. When we talk about the definitions of, hospice, of course, is compassionate care for people with life-limiting illnesses, and hospice care is a little bit different than palliative care, and we're going to talk about that a little in a few minutes. But what I'd like to show you here, and I think this is one of I use this when I talk pretty much everywhere about palliative or hospice care to give people an idea of what it is. I like to think of palliative care as being the entire umbrella. And you think about, let's say, for example, a cancer patient, they get their diagnosis, and initially, they're probably going to have a lot of chemotherapy, radiation, surgeries. So very much the focus of their care is curative or life-prolonging interventions. So that's where it shows here that, at diagnosis, but there's still this little piece here for palliative care, and this is where we should be starting palliative care. Unfortunately, many times we're way over here when we start, but this is in our ideal world, that at diagnosis, palliative care is present, but it's maybe just a small piece, once again, depending on where they're at in the disease trajectory and how late of stage they are, all of those things. But then as they start to go down the disease trajectory, depending on what it is, they are probably going to have less and less curative or life-prolonging treatments, and there's going to be more and more of a need for palliative care. And at some point, they become eligible for the hospice benefit, which is when they have a provider say that they have 6 months or less prognosis, and then they can become eligible for the hospice benefit. And also at this point right now, the patient decides that they no longer want to receive life-prolonging interventions, and they just want to have curative or comfort treatments. And then the other important piece is to understand that at death, that hospice and palliative care doesn't stop when the person dies. We have this bereavement, and it's typically a year after the person dies that the family or significant others have the ability to access hospice services for bereavement care. So that's just a brief overview. So I'd like to talk a little bit about the differences between palliative care and hospice. So if you'll see here, the NQF is the National Quality Forum. It basically states that palliative care means patient and family-centered care, optimizing quality of life, which really anticipates, prevents, and treats suffering. Palliative care throughout the continuum of illness involves addressing all of those different things: physical, intellectual, emotional, social, and spiritual needs, facilitating autonomy, access to information, and patient choices. It's really rooted in the interdisciplinary model of hospice, which we all know, but I think it's important for us to understand, the definitions. There's different definitions of palliative care also, and HPCO has a definition, and then the World Health Organization has their definition of palliative care, which essentially they say that palliative care is an approach to care that improves quality of life for patients and their families who are facing problems associated with life-threatening illness through the prevention and relief of suffering, and I like this next part here, by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And that's what we're going to really focus on throughout this course, is all of these different pieces, and give you hopefully as much information as you need, and then also resources to adequately address this holistic nature of palliative care. So when we think of palliative care, features of palliative care, probably one of the biggest things is this focus on the interdisciplinary team. And we're going to talk about the interdisciplinary team throughout the course. And essentially, of course, with palliative care, patients, families, palliative and non-palliative healthcare providers provide and collaborate and communicate about all the patient's needs. The other important thing to note, the difference between palliative care and hospice, is palliative care services are concurrent or independent of curative or life-prolonging care, where, remember, with hospice doesn't usually kick in until prognosis of 6 months or less, and the patient has decided that they no longer want to receive curative treatment. And you're going to have an entire lecture about the whole hospice and hospice benefits. So this is just, remember, just an overview. And then palliative care extends the approaches and principles of hospice care to a broader population. So essentially, I like to look at it as taking hospice care and moving it forward, so that we're taking all of those great things and we're implementing it at diagnosis instead of waiting until the end. So I like this little picture here. It kind of shows you, that all of hospice care is palliative care, and it's all in this circle. And hospice is just one little piece of the palliative care package. So here's kind of a little chart here to talk to you a little bit about the differences between hospice and palliative care. When we think about hospice, prognosis of 6 months or less, the focus of hospice's course is on comfort care. There is the Medicare hospice benefit, and really that's the reason that we have to separate out hospice and palliative care. In many other countries, I've worked in some developing countries, they don't really have to separate out hospice and palliative care because they developed it kind of after us and they don't have to worry about an insurance benefit that it's all palliative care. For example, the HIV patient in Africa gets palliative care from the beginning till the very end. Because that's the way the system was set up. But unfortunately, the way Medicare has looked at it when our hospice first began, it became the prognosis of 6 months or less. Maybe in the future we'll see some changes in this, but as of right now, this is what it is. And then one of the other things that I like to bring up about hospice is the volunteers, because that's one of the requirements of any hospice program is they need to have volunteers and they need to have a certain percentage based on their volume of volunteer hours that the hospice is actually integrating into the care. And then palliative care. Once again, there is actually a reimbursement too for hospice. You're going to get this in a later lecture that's going to be much more detailed. Palliative care can occur anytime during the illness, and it can, so once again, like I said, the ideal time is to begin it at the diagnosis. Doesn't always happen, but that's ideal. And it can be combined with curative care. It's independent of the insurer, so what this means is sometimes your insurance may cover palliative care, sometimes it doesn't. I think what a lot of inpatient facilities are doing now, they may not be able to bill or reimburse for everything, but the hospital is seeing palliative care as a cost saver. For example, they can maybe move that patient out of the ICU earlier that's been there for 30 days, help with some decision making, those types of things. So they're kind of funding it that way. And then complementary therapy is often included in palliative care, but then once again, that's also maybe included in hospice care also, just depending upon, of course, where you're located and what's available. Just a quick overview of who should we consider for palliative care. So when we automatically think about palliative care, we think about those patients with chronic diseases, and typically many of us immediately think of cancer patients, of course, because many times their illness trajectory and their prognosis is a little bit easier to identify than the congestive heart failure patient or the Alzheimer's patient or somebody with other chronic diseases. But really, many of our patient populations who have chronic diseases and may have other family or psychosocial issues can be definite candidates for palliative care. And it may just be that they're only seen when they're admitted, or depending on if you have the wonderful opportunity to have an outpatient palliative care clinic, that's wonderful, but not always applicable to your geographical area. And then anybody with other types of life-threatening illnesses, maybe it's not a chronic disease, but maybe they've gotten an accident and they're in the ICU and things aren't looking good and a very short prognosis. That's and then that's the time for maybe the palliative care team to come in and speak with the family. And then, of course, neonates, children's, adolescents, and adults, you're going to have very specific modules later on about palliative care for these populations, the seriously terminally ill. And then we're also later on going to talk about vulnerable populations, underserved and under-resourced populations, and how we can best provide palliative care to all of these different populations. And I think that's the thing that is important about this slide, is just to realize that, you know, palliative care isn't just for dying patients, it's for many different types of patients. Just a quick note about palliative and hospice delivery settings, and we're going to talk more about this once again later on. Of course, hospice can be delivered in the home, and much of the time it is delivered in the home hospice. And then there are some services, palliative services, that actually do go into the home, either through home health or through hospice agencies. But I would say we probably don't see as many of those as we'd like to have, and it really has boiled down to kind of funding issues most of the time. So maybe we'll see more home palliative care in the future. And then, of course, the hospital setting, hospice can be provided in the hospitals, once again, depending on where you're at and what your location is. And this is where you'll really see more of the palliative care programs are in the inpatient hospital settings. Long-term care facilities, many times hospices go into the long-term care facilities to care for some of their patients, and then assisted living facilities also, and then other types of settings, you know, prisons and homeless populations, and many places where we can provide hospice and palliative care. also another thing we need to consider in providing hospice and palliative care is the entire interdisciplinary team. So when you think about the interdisciplinary team, many times it starts with the primary physician, and that could be their oncologist, their internal medicine physician, essentially the physician that has diagnosed them with their terminal illness or their condition, and then typically that person stays involved in their care depending on, whether it's hospice care or palliative care, and then the hospice or palliative physician or advanced practice nurse becomes involved if it's palliative or if it's in the outpatient hospice setting. So depending upon whether it's a hospice or a palliative care, the role of the APRN may be different. For example, inpatient palliative care, the APRN may be very involved at bedside care of that patient, prescribing, writing orders, dealing directly with the team on the floor, whereas the hospice APRN may be more involved peripherally, maybe educating the RNs or providing education, consultation, and then also doing recertifications for some of the hospice patients, possibly making home visits, just really depending upon the facility that you're working in and what their needs are. Many times in the outpatient hospice setting, the registered nurses are the ones that are pretty much managing all the patient's care and communicating back with the physician or the advanced practice nurse regarding orders on the patient. So the role may be different, like I said, for the APRN, depending upon whether you're practicing in inpatient palliative care, outpatient hospice. Many outpatient palliative care programs are beginning, and many of those are run by APNs, just depending upon what's available in your area and what the needs are. And then we come down to the psychosocial professionals, and that's our social workers or counselors. And essentially what their job is to provide psychosocial assessment, look at family dynamics, social emotional interventions. These are the people who will typically do the bereavement assessments and then also the bereavement care after the death has occurred. Many times it is the social workers who run the various support groups and one-on-one type counselings. They provide other types of support to patients and family, community services that might be available, advance directives, financial issues, legal issues, funeral arrangements, many of these things that they can do. And then we have spiritual professionals, and the spiritual professionals really depends upon what the patient and family desires. They may have their own strong spiritual support group, and the role of that palliative or hospice chaplain may be very minimal, or it could be they could be heavily involved. It's just one of those situations where it's really based on the patient and their family preferences. Things to know about the hospice chaplains, though, for the most part, their approach is very non-denominational, although you may have a Protestant chaplain. He or she will practice in a very non-denominational approach to the patient and the family. They provide prayer, rituals, rites, life review. They can also do some provide help with planning memorials and funerals and things like this, so we can have much more proactive approach. And then we have home health aides and CNAs. The CNAs, or certified nursing assistants, can be a very valuable part of the team because many times they're the people that are right there at the bedside providing that care all of the time. So it's real important that we have a good relationship with them because they sometimes have more an idea of small changes that are occurring. For example, they may recognize a pressure ulcer because they're out there 3 times a week, and we may only be out there, once a week or even less than that, depending upon, the patient and family situation. So real important that they understand how important their role is on the team. And then when we talk about caregivers, caregivers can be many different things depending upon the state that you're in and how you practice. For example, I practice in Oregon, and we have a wonderful system that provides caregivers through the state healthcare system to many patients who need home help. It doesn't necessarily mean that they get direct hands-on care. Most of the time this isn't provided, but the caregivers can go in and they can help with small chores, shopping, light housekeeping, preparing meals, things like that, depending upon the patient's situation, maybe a few hours a week, or it could be as much up to, 20 hours a day, just depending upon the needs of the patient and what the availability is. But the majority of time, the caregivers are family members, significant others, and spouses who may have no experience being caregivers, or they may have quite a bit of experience being caregivers. And that's one of the core things that we need to assess, is how much support can we provide to that caregiver, and what do they need. And then volunteers. Volunteers are a major part of hospice. All Medicare funded hospices, or Medicare certified, I should say, hospices, have to have a volunteer component. And they actually provide volunteer training, and the volunteers go through this training, and depending on the volunteer skill set, they could provide anything from going into the home and being a companion, doing some shopping, light housework, things like that. Or they could, if they have a skill set, maybe they play a musical instrument, or they have, can do pet therapy or massage therapy or something like that. They may be able to be utilized for some of those skills. And then many times volunteers don't want to do any direct kind of patient interaction, so they may volunteer actually at the hospice doing administrative activities, answering the phone, doing some filing, things like that. So a real important part of the hospice team. And then there's the nursing piece, and we talk about, nursing, and what does nursing bring to the table. Depending upon, what the hospice has, many times there's registered nurses, and then LPNs who may also be providing the care. And typically in home hospice, the registered nurses perform very autonomously and work off of standing orders, and do a lot of communicating back and forth with the primary physician or the hospice physician or APRN, whoever's managing that patient. And then they do a lot of the education and interventions in the home. So the role, I would say, of the advanced practice nurse in home hospice is probably a little less away from the bedside and more in a consultative type role, unless they happen to have a palliative program where the role of the APRN may be more heavily involved in seeing patients. In the inpatient setting, and for example in a hospital setting, the role of the APRN is, like I said, typically the person who's seeing the patients and providing much of the care and writing orders, and working kind of with the nurses, kind of on a supervisory type relationship. I do want to talk a little bit about the dimensions of care. So when I talk about the dimensions of care, essentially Dr. Ira Byock, who many of you may have heard of, he's pretty famous in the world of hospice and palliative care, and Merriman in 1998 authored what was called the Missoula VITAS Quality of Life Index, and it says a tool that's used to measure quality of life in hospice patients. And really, this tool assesses the 5 dimensions, and I like this approach because it talks about really, what we approach as advanced practice nurses in caring for hospice and palliative care. And it shows here that they're all across a trajectory, showing that, one isn't more important than the other. So sometimes, the physical symptoms may be the primary issue, or it could be that they have interpersonal issues that may be the primary issue and very few physical symptoms. So understanding that it really isn't a hierarchy, it's whatever the patient needs at that time. So when we talk about physical symptoms, the physical and symptom dimensions, this is of course where the patient's experience of the physical discomfort that's associated with the disease process, their level of distress, and the caregiver's experience of their response to caregiving. And this can include things like fatigue, health issues, speaking of the caregiver, and then of course all the pain and symptom management issues that can come along with their disease process, and that you're going to have several weeks of information on physical symptoms. And then we have the functional dimension, and this is the patient and family, their perceived ability to perform the activities of daily living. And this can include social functions such as like paying their bills, childcare, employment, all of those daily things that change when somebody gets a terminal illness or starts coming to the end of their life, and how can we best support that? Once again, it doesn't mean that at the APNs we need to be the fixers of all of these different dimensions, but we need to find our assets. Maybe that's where we have to pull in the social worker, that this person is having, some issues or concerns. And then we have the interpersonal dimension, and this is the degree of investment in personal relationships and perceived quality of those relationships with family, friends, and others. And it's also inclusive of the caregiver's perspective too. Kind of like pediatrics, the patient isn't our only patient, the family is kind of our patient also. So those interpersonal issues, and how can we help this family get through those? Those of you who maybe have some hospice or palliative care experience have been in those situations where there's been, pretty significant family dynamics throughout their entire life. And now you add a significant illness to that, and it many times will make it much, much worse. And sometimes we can't fix all of that history. We just have to figure out how to deal with the here and now for right now and help that patient and family to have the best quality of life that we can, and help them work through some of those issues if we can, or whatever we need to do to support them at that point. And then well-being dimension. This is essentially when you think about a self-assessment of the patient. For example, what is their sense of wellness? What does that mean to them? Their personal sense of well-being, how they feel about themselves, do they, and their feelings such as anxiety, sadness, depression, do they have a sense of peace? Those phases that we learned Dr. Kubler-Ross, are they in the depression stage or are they angry? And then how do we help this family to understand this, or this caregiver to understand that? So that's one of the dimensions that we're assessing. And then the last one here is transcendent dimension. And this is the patient's and family's degree or connection or relationship on a transpersonal level. And this can include spiritual and religious values, but doesn't necessarily just mean spiritual and religious values. It can mean things such as perception and the meaning of life. What is the meaning of life to them? Suffering, death, their beliefs in the afterlife. That's all the part of the trajectory of the dimensions of care that we're providing to our patients and families. Dr. Ira Byock talked about that assessment of these dimensions can be real useful for encouraging and supporting collaborative care, because we're addressing all of these multiple dimensions that can affect a patient's quality of life, and understanding that, a change in one dimension can affect other dimensions. So to assess pain only in the physical dimension would really not allow us to fully understand the pain experience, meaning that the person may be experiencing a lot of pain, but if we just focused on increasing their narcotic but don't deal with some of the psychosocial or the well-being issues that they're having, then we may not really be fully treating that patient holistically. And that's part of the philosophy of hospice and palliative care, is being able to bring all of that to the table and provide this patient with the best care possible. And then the last thing I want to talk about real briefly is resource management. And the reason I added this as the last slide is because you've now had kind of a very, very brief overview of the history and the philosophy of hospice and palliative care, just to kind of like lay the foundation, I guess. And then some of the other things that affect, how we provide hospice and palliative care. Originally hospices were funded mostly by charity grants and volunteer efforts. The hospice I worked for in Oregon was started by several nurses who saw the need to start a hospice, and they did it all as volunteers on their own time. And now, of course, it's the hospice in the area, and it's basically funded now. Nobody works as volunteers anymore unless they want to. But that's how hospices really started out. So today we have the Medicare hospice benefit, like I said, that was enacted in 1982, and that's many times the main source of payment for most hospices, although there are patients that maybe have private insurance that pays for hospice if they're, not old enough to have the hospice Medicare benefit. And when we think about private insurance, financial concerns can be a huge burden for many of our patients and families providing care for their patients during a terminal illness. Most private insurance plans will pay for hospice care, but the thing to know, though, is that hospice care is provided regardless of their ability to pay. And with palliative care, reimbursement for palliative care is varied. Like I said earlier in the lecture, sometimes insurances cover palliative care, but many times they do not. It's just because it's a newer field, I believe. And then we think about access to care issues. Unfortunately, many times patients don't get access to hospice until they're within a few hours or days before death, of course, which is many times too late for them to really access the benefit of that whole interdisciplinary team. The same thing with palliative care. Maybe the CHF patient is on their, fifth admission in a couple of months, and just now palliative care is being consulted to come see them, and that's the unfortunate reality, but that's part of how we can move palliative care forward is to put some criteria and some triggers into place. How can we start to see these patients earlier? How can we give them better access to palliative care? And then we think about like palliative care reimbursement. I had talked about that a little bit already, that we really don't have as much reimbursement for palliative care as we do for hospice care. Hospice care has been around, like we said, for quite some time, so the hospice Medicare benefit is pretty well organized and set into place, whereas we're still kind of, with palliative care, kind of fumbling our way through reimbursement issues and funding issues. Although hospitals are increasingly adopting palliative care programs, the investment in palliative care, of course, is necessary, and many hospitals are seeing it as a form of saving money as opposed to making money, because maybe they can get that patient out of the ICU a little bit earlier, and that may save them money. So I'd like to end here because we're going to, like I said, this was very much a brief overview of hospice and palliative care, and I hope it has started to lay a little bit of the foundation. Here are some of the references, and we'll see you in one of the further lectures.